Dr. Jeff Belkora. Dr. Belkora is involved in patient support decision-making research both here at UCSF and in several national and international initiatives. His work and efforts have received several accolades, congratulations, from the Mayo Center for Innovation, Department of Health and Human Services. And today he's going to talk to you about tools and strategies that you can actually use in your practice to foster shared decision-making with your patients.
Thanks. Thank you, June. Hope everyone's doing great. I'm excited to present today. I've designed a learning experience for you that has many components, or several components. The slides are numbered. This is a lost art. The reason I've numbered the slides is so that you can write down questions, because I'm going to go through, I want to give you a very quick overview. And if I'm on a slide that you'd like to hear more about, I'm going to leave time at the end for questions. So write down the slide number, and I'll come back and elaborate on it during the Q&A. And then also, some of the slides are so important that my colleague Shelley has written them up on posters here. So, for example, you can keep track of the agenda and where we are in the agenda. This first poster has my phone number, and if there's anything that I don't have time to cover in the lecture, you can email me or call me or talk to me afterwards, whatever's convenient. So I'm going to go through at a pretty quick pace, like I said, to give you an overview, and then you can interrupt me for clarifying questions at any point. But as I said, if you really want me to elaborate on something, save it for the Q&A and make a note of the slide number. My disclosures here, I don't have any serious conflicts of interest. The Foundation for Informed Medical Decision-Making funds my work and also creates some of the decision aids that I'm going to be discussing today. So that's just something you should be aware of. By way of acknowledgments, I really want to thank patients who participated in the programs that I run and given us a lot of data and feedback, and the funders. And Laura Esserman, who's pictured here, is the director of the Breast Care Center, and she's really the way I got into this whole field in the first place and continues to be a real clinical champion and sponsor. I want to tell you just a few definitions before we get started. Shared decision-making, there's probably many definitions in the literature. The one I like is it's the art and science of informing and involving patients in treatment decisions, mostly treatment decisions, also in other areas in the spectrum, screening, diagnosis, that kind of thing too. But a lot of the time it really refers to treatment decisions. And it's important to note about the word shared decision-making that the whole field has embraced a view of patient autonomy and self-determination, such that even if a patient decides to delegate the decision to a physician, which is a perfectly reasonable thing for them to do, that's included in the definition of shared decision-making, that kind of participation where a patient might say, I want you to make the decision for me, doctor. And really the goal of shared decision-making is good decisions, which in the field we define that as decisions that are based on valid information, valid in the scientific, replicable, transparent sort of meaning of the word, and also on well-considered patient preferences. So well-considered meaning not fight, flight, freeze reactions based on fear, etc., but well-considered usually involves some deliberation about what your long-term core values are and what your goals for treatment are. Decision support is just the technologies and techniques to inform and involve patients, and I'm going to be talking about specific technologies, decision and communication aids. In this lecture, a natural question that arises is, well, what's really the point of informing and involving patients? And obviously one of the points, the main point, is that it's the right thing to do. It's actually part of patient-centered care. It's an outcome in itself. It's an irreducible outcome. People also ask questions about, well, once patients are informed and involved from an ethical point of view, do they have better other kinds of outcomes, like better health outcomes or better cost outcomes? To me, those are just questions about the side effects of informing and involving patients. Again, the main point of informing and involving them is that that's the right thing to do ethically. It turns out the evidence is a little mixed. It's actually hard to study. There are probably good psychological benefits from informing and involving patients, and maybe in some cases even physical benefits. In terms of cost, it appears that the best thing you can say about informing and involving patients is that it seems to lead to more appropriate treatment utilization And so in areas of overtreatment that will save money, and in areas of undertreatment that will cost more money. So again, ethically, I'm all about, and I recommend being all about, appropriate levels of resource utilization. So my professional mission is translating what is good and true about shared decision-making research into practice. And I'm going to be talking to you about that today. When I say practice, it doesn't necessarily mean that you as physicians, that in your practice, your behavior, I'm not just targeting kind of your practice, your behavior. I'm also targeting your interaction with the entire system. So if you're looking today in this lecture for risk communication strategies, I'm going to be pointing you to some of those, but I'm really going to be pointing to a lot of organizational things you can do. And overall, my goals for this lecture are, we talk about in curriculum development, the affective, cognitive, behavioral kinds of goals for learning. The primary affective goal is to inspire you to see decision support as something that you can embark on a lifelong journey towards. And then a cognitive goal is just that you become more knowledgeable about evidence-based decision and communication aids that will help patients make good decisions. And the behavioral goal is for you to know, even as you go into further training, even before you're practicing independently, how you can intervene with whatever system you're in to incorporate more decision and communication aids into your practice. And so overall, the outcome for today should really be that you emerge with a little increased self-efficacy, motivation, confidence, knowledge, access to resources on how to be implementing decision and communication aids so that you can be guiding patients to good decisions. So I'm going to talk briefly about the patient journey through cancer decisions, and then take you through these evidence-based interventions, and then make some prescriptions or recommendations for your practice. So it's really in the last third of the lecture that we're going to bring it home to, what's in it for you. Okay, so, and just by way of context, all of this links very directly to the ACGME competencies around compassionate care, incorporating social behavioral sciences. Decision sciences definitely fall into that category. Really reflecting on your own practice and thinking about continual improvement, and communicating with patients, professionalism, and systems-based practice, calling on system resources. So the patient journey, and you should be familiar by now in this M3 with this kind of cancer care continuum. We're all on this journey, right? We're all in the, if we're sort of healthy right now, we're in the prevention, detection stages. If we live long enough, we're going to end up in the diagnosis, treatment, survivorship. And since this graph was made, there's of course also palliative care, end of life as another phase in the journey. Actually, I'm told Jane Hawgood says we should be using the more patient-centered term for palliative care now as advanced illness. So I'll be incorporating that. But it's not just about the patient going through these kind of disease phases. It's also about how patients are interacting with the healthcare system. So I've created this simple model, a flowchart that shows you, again, we're all on this journey, and we and our patients experience disparities and barriers at every step of the journey. So we're all monitoring our health, hopefully, some better than others for various reasons. Ideally, we detect problems, and maybe we need some navigation assistance. That's one of the interventions that's out there in cancer care, to access appointments and be seen by, in cancer, usually specialists. Then in number 4, we visit the professionals, and afterwards, of course, we debrief these visits with family members and friends and others. And if we're in the specialty care environment, we're probably looping through what I call this visit cycle multiple times. So it's not just one specialist, it's multiple specialists, and that creates care coordination issues. Eventually, we hopefully exit this visit cycle and decide and take action, which involves adhering or following through with treatment recommendations or not. That's an area of care planning. And then we're back in survivorship and monitoring our health. So that's anytime you're interacting with a patient who has a cancer diagnosis, you should be aware from a decision-making point of view that you're just interacting with them in one sort of touch point on this whole journey. And there are decisions and barriers and disparities at every stage. So I got very interested as a graduate student. I'm a systems engineer by training, and I got interested. I met Laura Esserman at Stanford when we were both there. And I got involved with a community-based organization that was doing a needs assessment. And so the qualitative needs assessment they were doing actually spanned the whole spectrum of needs. But I drilled in, based on my training, on the information and communication and decision needs. And so what I found was actually pretty common sense. But we surfaced these kinds of issues where patients were telling us, and these were breast cancer survivors, but it turned out that these needs were pretty universal across many cancers, that there was often a gap between being diagnosed and actually being seen to start discussing treatment options. A few days, a week, even a few weeks sometimes. And that during that gap, people really experienced a need for better information because they said, I had either too little or too much or conflicting information. And I was sort of being left to my own devices to process that kind of whatever level of information, whatever quality of information you're on your own. And then they said, and you know, I'd be lying awake worrying about questions and concerns and worries. And then I'd go into my doctor's appointment, like usually you're seeing a surgeon, a specialist. A surgeon might be the first specialist you see. And I would freeze up and forget to ask the very questions that have been keeping me awake. So that's a tragic kind of dynamic for someone to go through in their care experience. And then even if the doctor did answer my questions, the information would go in one ear and out the other. In other words, I would not retain the information. And I think you've heard from Diane Shumay and others about the emotional impact of a diagnosis like cancer. So you can understand that kind of freezing up and sense of overload. So we just repeated this needs assessment in a more quantitative terms, and I was surprised even that much later, between 1994 and 2010, things had not really changed that much to the point where people were saying, well, yeah, I would go in and see a specialist. And amazingly, even though in many cancers, and this was also breast cancer, but in many cancers there's no urgency to making a decision on the first visit with a specialist. And yet 52% were arriving at a decision in their first visit. And they were doing that in the absence, really, of having had any information support prior to that visit. So they were not getting information materials from their doctor's office. And even in this age of the internet, polls show that patients prefer to get information from their physicians. So they were not getting information support, and then that puts a lot of pressure on one visit if you're going to try to arrive at a decision. So it's very hard to understand how patients could be really informed and involved if they're coming in cold and then they're trying to absorb a lot of information, which we know they don't absorb and retain very well. And then 34% in this survey said that they'd forgotten to ask questions that they wished they'd asked. So just to summarize in very plain terms, and this ought to be accessible to you based on I know from my experience going to the doctor and with my kids or your family members, this kind of thing happens to me all the time. There's challenges in gathering information before you go, in asking questions when you're there, and then remembering responses afterwards. All right, so let me take a deep breath here. Is everyone following? Is there any need for clarification at this point? Because this is really setting the stage in terms of the needs that this lecture is going to focus on addressing. Okay, I'm getting some nods. So the evidence-based interventions then are, there's a whole field of shared decision-making that across the whole spectrum of cancer, there's many different skills and many different aspects to it. And I'm going to focus on the sort of slice that relates to exchanging information. That's what those needs really are about. Information, asking questions, remembering responses. But I do want you to know, that's all I can do in a 50-minute lecture, but I do want you to understand all the other needs and issues that probably you've been hearing about from Diane and others around healing relationships, emotions, managing uncertainty, and enabling patient self-management. So those are some of the other dimensions and there's a good reference here. All these slides are really intended for your reference as well. So there's a great publication on patient-centered care at that URL that you can access, and an article about shared decision-making in the sort of seminal article on shared decision-making from Kathy Charles. So we're going to be talking about these particular kinds of interventions. It turned out when I got into this field, I felt kind of lucky that we identified a need, And then it turns out that there were evidence-based interventions that had been systematically reviewed by the Cochrane collaboration, where they showed decision aids, these kinds of multimedia presentations that take a patient through the crossroads that they're at in terms of treatment options, and then what the outcomes are, both in terms of benefits and also in terms of side effects and risks. And they may be print materials, they may be audiovisual, they may be web-based now, of course. So those things are out there, and they exist, and they definitely have beneficial effects. The systematic review has done meta-analysis and shown. I focus really on the educational benefits. So the thing I'm really focused on is that they increase knowledge. There are also other benefits. Question listing increases question asking. It turns out that a systematic review shows a pretty modest impact, but also their interventions were very modest. So I've taken that work and sort of turbocharged the interventions, and I think we're seeing more significant effects as a result. And then summaries and recordings, after visit summaries and audio recordings, when you give them to patients, they increase recall. So this really should not be surprising to anyone. This is very common sense, and it's still important to have the evidence and be able to move forward with some confidence that these are the effects. I'm going to skip over the next few slides that just kind of summarize what the systematic review said, but there are multiple randomized controlled trials of decision aids and question listing and audio recording and note-taking. So these references are here for your reference. So the question then arises, well, who's going to deliver decision and communication aids? Because if these things are effective, then we get into the area known as implementation science around, well, how do we actually integrate them given the current so-called healthcare system? You know, how can we leverage the resources and the infrastructure to make sure that as patients go through this journey that I showed you earlier, that at the right time they get the right decision aid, that they get the opportunity to make a list of questions and get that list of questions to their doctor, and that they have notes, recordings, and summaries to review afterwards. So I'm going to tell you now about how Check 2. Okay, we're back. All right, so where was I? Yeah, so we're going to integrate these decision aids. And so how do we solve this problem at UCSF? And I'm going to tell you about this particular situation, and then I'm going to suggest how it might be generalized, because I know some of you are going to be saying, well, that's nice at UCSF, but what about other places? So let me tell you about it first, how we did it here, and then we'll look beyond. Oh, yeah, so we use health coaches. The general notion of a health coach is really emerging as a kind of a task force innovation, right? A health coach can be somebody who is has some training, but is a much more well-adapted resource where their training is adapted to the task that they need to engage in, and really the cost of paying this kind of person is adapted to what their task is. So at UCSF, in the Breast Care Center, we've created a demonstration project where we use pre-medical interns. And a few of them are graduates of this program are in your class, and we'll be hearing from one or two in a minute. So we've now gone through several successive generations where the interns, well, let me ask Alexandra to tell you about what they do.
Hi, as Jeff mentioned, my name is Alexandra, and I am one of the pre-meds. There are 10 of us total, and among the 10 of us, we divide our coverage at the clinic. So I cover Monday mornings, and what that means that I call all newly diagnosed breast cancer patients that are coming in for Monday morning appointments. So for example, let me tell you about the last patient I worked with named Anna. My first job was to figure out if we had any educational materials that might be helpful to her. We have a series of 5 educational DVDs and booklets, and they're developed by the Foundation for Informed Medical Decision Making and range in topic anywhere from precancer to metastatic disease. So part of my job is to send the right materials to the right patient at the right time. So I sent the materials to Anna, and after she had a chance to review them, over the phone, I helped her develop a list of her questions and concerns for her doctor. I then organized them into a list and emailed them to the doctor so he'd have a chance to look them over before her appointment. Then the day of her appointment, I went with Anna, and on a laptop I took notes while audio recording on a little recorder like this. And at the end of the appointment, I was able to give her a copy of a summary of my notes as well as an audio recording on a CD, which she was able to listen to when she went home with her family. At the end of all these exchanges, Anna sent me an email, and I wanted to share an excerpt of it with you guys. She wrote, "I cannot imagine having my questions, fears, and concerns being addressed if it wasn't for you. You're going to be a wonderful, caring doctor in the future."
Oh, yeah, very nice. So that was Alexandra talking at the Mayo Clinic Center for Innovation, and I think it's just a happy memory we both share of getting ready for that lecture. That was probably the hardest. It was like one of these TED Talk kind of environments where we worked probably for 3 weeks on a 10-minute presentation, of which Alexandra was clearly the star. So again, we're going to get in a minute as to how this generalizes to hopefully the way you're going to practice medicine very shortly. But I do want to take you through some of these steps that Alexandra mentioned, including, well, what is a decision aid really about? So I'm just going to show you a very short clip of how the decision aid, which involves patient testimonials and discussion of side effects and other things as well. But one of the important things it does is communicate risks and benefits. So let's see how they do that.
You may have been told that on average, chemotherapy can reduce the chance of cancer coming back by about 25%, by 1/4. To see what this means, we'll compare women who didn't take chemotherapy with women who did take it. In each case, we'll see how many were cancer-free after 10 years. These numbers are also in the booklet that comes with this program. Women before the age of menopause, generally those under 50, may get better results than the ones shown here. Results in women older than 70 may not be as good. Of 100 women who have already had either mastectomy or lumpectomy with radiation, with no additional treatment, about 76 will be cancer-free at 10 years. This estimate is for a group of women whose chance of cancer coming back is about average. If all 100 women take chemotherapy, more will be cancer-free. Although some women who take it will still have cancer come back, there are about 6 more women in the chemotherapy group who are cancer-free at 10 years. How much chemotherapy might help you depends on the type of treatment you have, your age, and overall health, and the characteristics of your cancer.
So as you can see, the patient Anna that Alexandra was talking about got this material in a DVD and a booklet in the week before she came into a consultation with, in this case, a medical oncologist. And this is not something that's going to replace a medical visit. It's more an orientation to get someone to a higher level of baseline understanding so that they can ask better questions and be more informed and involved. So, in fact, I want to now show you, or have you just listen to an audio clip of another one of your classmates. This is Jossie calling a patient and just starting the conversation. I wanted you to understand what a health coach does. We train them to be neutral and non-directive, so they're not giving information or giving advice. They're not qualified to do that yet, but they are able to interview the patient and get the list of questions and concerns. We're just going to listen to a very short clip here.
Back over here. Okay, everything's working. Okay. So what I have with me right now is sort of like a checklist of different sections and types of questions that we can sort of tease out. And the first part is sort of about your situation. Any questions that you might have about key facts, about your diagnosis, and things of that nature. So what I'll do is just sort of type down questions while you dictate them to me, and then maybe probe further. So, yeah, do you have any questions about your diagnosis or maybe some test reports?
Well, I think the pathologist didn't quite complete the entire pathology report, and of course I have the slides with me, so hopefully someone there can. I had 2 masses, and he did completely, pull apart the larger mass. But the second one.
So the patient's a little hard to understand, actually, in this. At least I'm having difficulty. But the idea is you get a rehearsal before you come in to see your doctor. You're spending 20 to 40 to even an hour, 60 minutes, with a coach over the phone who's typing up your list of questions while interviewing you in this non-directive, neutral way. And did we get a chance to hand out the? Did we get out the handouts, or you guys have? Okay. So on the first side, the side that says the question list, this is an example of a consultation plan or a question list document. And on the back side is an example of the summary that's created. So I just put a little excerpt here to show you. This ends up being we try to get them all on one page, a one-page summary that gets forwarded to the physician in advance. So when the physician arrives, in this case a medical oncologist, arrives at the appointment, as part of the chart review, they've seen the patient agenda. And that's very important for in terms of having a productive consultation. So then I thought I would just have you listen to an excerpt of an actual audio recording. This is one of our medical oncologists talking to a patient with one of the pre-medical interns, not just taking notes on the laptop, but also making that audio recording.
14 is not a big deal to you, is not worth it to you, then you don't need to do chemotherapy. If you're the kind of person that says, I understand this, biologically the tumor looks a little bit more aggressive by its genes than it did, by its numbers.
Got it, yeah.
And only you can answer the question.
Right.
My feeling is I would probably offer you chemotherapy based on this number because you're very young and very, otherwise very healthy. Yeah. And so
Okay. What kind of chemo would you be talking about?
Well, so there would be 2 choices. We would offer you either 4 cycles of adriamycin and Cytoxan or 4 cycles of Taxotere and Cytoxan. And
Okay, so now if you look on the back side of the handout, you're seeing a summary. The patient leaves with not just a recording that they can listen to, and they do listen to, but also a written summary that kind of summarizes the high points, the takeaways. And so just to give you a sense of how patients are reacting to this kind of thing, I have video clips, but in the interest of time, I think I'll just show you a couple of quotes. This patient says about the decision aids, this was exactly the material I was looking for all over the web, but having a hard time finding in a consolidated format that made sense. And then because the decision aids also show a carefully selected range of women who are kind of representative of people who made different decisions based on different reasons. Another quote is, it also helped tremendously to listen to women who have been there and made their own decisions. So those are some of the reactions we get very frequently about the decision aids. And then with respect to the communication aids, people are very appreciative of having both the preparatory visit and also the recordings and notes. And generally the impact in terms of our surveys and the evaluation is very consistent with the randomized controlled trials. So when we put this into practice, we find that people have pretty much the same kind of increase in knowledge, from 50 to 81% correct answers on essentially a quiz about breast cancer facts that they need to know. And also that they actually do review the booklets. They take the time to review the booklets and videos, even though the videos are like 40 to 60 minutes long. People are very motivated, and as you saw, I think the videos are very patient-friendly in terms of presenting information. Likewise, with the question lists, we find that on average, people come in with kind of on the top of their mind about 8 questions to ask their doctor, and after the coaching, which is really just interviewing them to elaborate on that initial question list, they come out with 21 questions. They do, in the future, review the question list, and 84% review the summary, and a smaller number, but still I think a pretty impressive 52% review the recording after the fact. Our providers are very happy with this, and sometimes there's different reactions. People do have concerns. Is this going to lengthen the consultation? No, it turns out pretty much what Dr. Melisko says here. patients are more prepared and ask questions that are going to use my time better, and I'm able to start from a higher level of explanation. So that's pretty much the kind of reaction. And we're starting to see, having taken a bunch of cohorts through this process, that the interns and the alumni find that this has this kind of experience of being a health coach has a really good effect on their professionalism and humanism and advanced communication skills. So this is just for your information. I'm expanding this kind of program now nationally and even internationally through something we're calling the Patient Support Corps, which is to take trainees. My goal, my vision is to have all kinds of trainees, whether they're pre-med or pre-nursing or pre-social work or whatever it might be that's health-related, and give them opportunities to work in meaningful ways with patients like this using decision and communication aids. And there's policy stuff happening. The Affordable Care Act has provisions for shared decision-making, and I don't have time to get into the detail, but the CMS Center for Innovation is also going to be pushing this. So hopefully by the time you emerge from training and into practice, there's going to be more activity. And hopefully I'm just giving you a preview of some of the environment. Not only at the federal level, but the states are also pushing initiatives for shared decision-making. Again, in the interest of time, I'm going to go kind of cut to the chase here with, so what does this mean for you? I mean, you're not going to be health coaches, you're going to be medical doctors. And that is a form of coach. But I guess what I really want to emphasize as a takeaway for you all is that in your practice, you will have the opportunity to influence these kinds of strategies, these 5 strategies. The first is you'll be able to find or create decision aids for your patients. And this is going to be true even in the near term when you're still in training. You're going to go out into environments where patient education in some cases may be a real afterthought if it's thought of at all. And so one of the things you can do as a trainee is kind of raise the level of awareness of the people you're working with to the availability of decision aids. And you may be involved in research projects or quality improvement projects where you can create a decision aid for whatever condition, whatever area of medicine you're working on. You can also get coaches to accompany your patients and help them make a list of questions and take notes and make recordings. And these coaches, they can be drawn from different walks of life. It does take some training, ideally, to have someone really know how to paraphrase and summarize in lay-friendly terms. But I would suggest that you can really be creative about finding coaches and including trainees who are a little behind you in their training and who may appreciate that kind of experience. There really is nothing, kind of more, well, it's just pretty heartbreaking to see people come into probably one of the most important meetings of their life alone. That happens. So when we're serving patients in the breast care center, we definitely try to prioritize people who are coming in by themselves and making sure that they have our support. We also tend to prioritize people who have language barriers or cognitive barriers. So whatever environment you're in, you can start with the people who have the highest need if you're not able to serve everyone in this way. And then as a physician or as a trainee, you can record your consultations and give a copy to patients. There is a little caveat here around you want to coordinate with your risk managers at whatever institution you're practicing in. But our experience has been the risk managers understand that this kind of thing is really protective for physicians, that complaints and conflicts are really about breakdowns in communication, and doing something that tries to enhance communication is incredibly protective. Another thing I think you can really do that's very practical is, I don't know why this doesn't already happen, dictated notes are kind of a mystery to me. It seems like their audience is like almost everyone but the patient. The medical legal reasons for creating a dictated note, the billing and insurance reasons, the interprofessional communication is all kind of taken care of. But what about the patient? So one thing I've seen from Kevin Bozick, who I work with in orthopedics here, is he dictates his note in front of the patient. And it's funny, I took my mother to see him about a hip issue, and he did that, and I was blown away. I thought, this is amazing, because he dictates the note and gets patient input at the same time and uses it as kind of a teaching tool to go over and repeat what he said, but also check for understanding and get additional questions. And I said, wow, why isn't everyone doing this? And he said, well, in fact, many physicians consider it disrespectful to the patient to do this like you're doing your administrative work on the patient's time. So this is the kind of nonsense that we need to get beyond in medicine. This is a really creative practice. And I think that doing that kind of thing and then routinely sending the patient a copy of the dictated note at least gives them some summary. And if you can do it in plain language, and that's all the better. And finally, this fifth strategy is study communication and decision aiding techniques. There's going to be lifelong opportunities for you to take workshops and engage. And when you're in a workshop, absolutely take advantage of the opportunities to role play and be active. And don't be afraid to fail and struggle because it's just going to make you better for your patients. So I'm just wrapping up with a few slides indicating some of the best resources I've seen. I would like and I recommend when anyone I know and love gets a diagnosis, this is a great book on sort of patient activation, how to go from being what many people experience as sort of a passive reactive patient to a really active patient. It's a very layperson-friendly book, but also worth reading for all of us in the field. And then, whatever environment you're in, one of the things you can do is, if you haven't been able to create a decision aid, at least make a list of the available resources so that your patients are not kind of drifting in the internet on their own devices. That we do this in the breast care center. We try to curate a list of really good resources for people. And then there is a decision aid inventory, so you can get online and look for decision aids. Many of them are in the public domain. If the Affordable Care Act kind of continues its progress and money gets appropriated, there's going to be more and more decision aids in the public domain. Some of them are sort of in the private commercial area where your insurance company has to pay for it as a benefit or something if you're a patient. But anyway, many of them are available. This is a resource for if you're going to develop your own decision aid. There is actually a good and a bad way to do it, and this is a checklist for the right way to develop a decision aid. And it's not something to enter on lightly. I interact all the time with physicians who say, oh, let's do a decision aid, and it's an expensive undertaking, especially because you have to keep it up to date. You have to maintain it over time. So I wouldn't even go there unless you're kind of resourced or really committed to updating it every 6 months or whatever it takes. And then finally, there's some interesting technology coming out. There's a company called Care Coach. I don't have anything to do with Care Coach, but I think it's a cool concept that on your smartphone, your patients can log into a website, develop a list of questions, copy it onto their smartphone, read it while they're in the interaction, and then press a button and record the interaction with their doctor, and even tag when the doctor actually answers one of their questions. They can press a little button on the smartphone. And then if they're sharing it with people later, you don't have to listen to the whole interaction. You can jump straight to an indexed view of where the question was actually answered. Like here's where the doctor talked about clinical trials or whatever it might have been. So I think I am working with Care Coach in terms of I think there's a few obstacles to actually implementing this, but I hope to be putting this kind of thing into practice in the breast care center and maybe beyond. Some of the issues that arise are, our risk managers want us to keep a copy of the recording whenever we make a recording. So, okay, and then finally some risk communication books that I recommend. And again, these are going to, you're going to have access to the slide deck, and you can pull any of these. The first two are really fun to read and very enlightening. The book Risk is about the kinds of risks that we actually face in the real world, so it's all about perspective and context for helping a patient understand how one risk relates to another. And the same thing with Know Your Chances. So these are great resources. And so I just want to conclude by, and hopefully I've allowed now 10 minutes for questions or a little more, just by revisiting that this is all about you maintaining your competency as a doctor and having this kind of notion of a lifelong journey that you're on and providing decision support, and knowing that whatever position you're in your training and beyond, you can make a difference by incorporating some of these strategies into your practice environment. So again, just to revisit the objectives, I hope by the end of today you're getting this kind of inspiration or motivation around the affective dimension, as well as some knowledge and some behavioral tips and strategies. So with that, let's see what questions you have. Yeah. That's, go ahead. What's your name? Asya. Okay.
So do you guys put your decision aids online?
Not yet. No. They're, it turns out DVDs still have the highest penetration of any technology. So 97% of U.S. households have DVD players. So the DVD is, and also the DVD actually presents an advantage to where people can sit down and linearly watch it, and in a way that's actually better. The kind of patient population we work with, 40 to 75-year-olds, hasn't really, it's a lot of material to assimilate. They don't sit in front of a computer screen watching 40 to 60 minutes of linear stuff unfolding. Having said all that, we're moving in the direction of getting the decision aids online. But I think it's still great to have even print materials and sort of linear DVDs and that kind of stuff is all fine. What's your second question?
You guys are having volunteers do the touring?
The coaching, yeah. No, they're not volunteers. Actually, I should have mentioned they're paid staff, but I've convinced, and Laura Esserman has convinced their bosses to lend them to me a day a week. So it's a kind of a job enrichment where they're being paid to do other stuff, but a day a week they get to do this stuff.
And
How much from a financial point of view? Okay, so yeah, that's a good point. The decision aids are donated, so UCSF is maybe not the best environment to talk about that because we're a demonstration project. So the decision aids are donated. Generally I would say that my experience is that you can pay someone somewhere between $15 to $25 an hour to do a really good job of health coaching if you train them well. In addition, through this Patient Support Corps, I'm trying to actually do it as a volunteer initiative so that trainees will do this in exchange, not for money, but for academic credit and for service learning experience. So and I'm hoping that'll become a national concept like Teach for America or the Peace Corps or whatever. So that's the dissemination hope that I have in terms of keeping it cost effective. Yeah.
You mentioned that the physicians like it, but how hard has it been to implement it and get people on board?
Yeah, so we measure sort of 3 dimensions of physician, and this is important for you guys when you are physicians and somebody brings this kind of idea to you. We measure physician cooperation, coordination, and collaboration. So the way we define those is cooperation is like you're going along with it, and coordination is you're actually really helping us logistically get this stuff done. For example, when you go in and you're running late and you go in to see a patient, you remember to grab the coach and bring them with you so that they can be there, because it's very hard for the coaches to know when the doctors are going in to see which patient. So a little detail like that makes all the difference. And then collaboration is when the coach is in a room with you taking notes or something, are you making their job easier? Are you repeating? And it's making the patient's comprehension better too. Can you summarize for them and work with them? So yeah, I would say that that would be my appeal for you all, is that when you're in that position that you cooperate, coordinate, and collaborate with whatever paramedical professionals are trying to do their jobs around you. That's really important. Let me take a few other questions and come back to you. Yeah, go ahead. What's your name? Uri. Yeah. Yeah.
Have you done work in other languages, and if not, is there anything in the works?
Yeah. So the question is, have we done this with other languages? We're lucky at UCSF we have a good interpreter system. And what happens is when the coaches call a patient to see if they need help and all that kind of thing, one of the things they determine is whether they need an interpreter. And we keep the coaching separate from the interpreter because the interpreter really should just be focused on language. So, and we can patch them in by telephone. There's all kinds of solutions. So both at UCSF and in the other environments where I've done this work, it's usually been possible to incorporate interpreter resources. Yeah, and we have definitely done this in many, San Francisco is so diverse, many languages. Yeah. One thing I don't do, though, is really I don't expect the coaches to be interpreters. Again, that's like these are special, keep these things separate. It's like family members shouldn't be interpreting either, that kind of stuff. Yeah.
So when the coaches in the room with the documented patient, do they just actively listen?
Yeah, so what are the coaches doing when they're in the room? I should be letting Alexander and others answer these, but just in the interest of time, they're sitting there with a laptop and taking notes. So they are actively listening and summarizing and paraphrasing. And they're doing that through something called a low inference method, so that they're not injecting their own interpretation. And that just takes some training, which we do up front, and then we do supervision. We have weekly case review meetings where we go over the documents and understand the skills. So the training, I have a couple websites. I didn't put them in here, but let me send an email to the course organizers about there's a scoped model and a select model. through which we train people on those skills. I'll send out the URLs for those. Yeah?
What are the resources available for spouses or children or friends or whoever are accompanying the patient in the visit to act as a health coach? So if there isn't access to a health coach, how can we empower
Yeah.
other family members to play a semi-health coach?
Well, you know, it's a tricky thing. The question is, what about if you don't have a health coach, can family members play this role? You know, family members are often emotionally hooked and not the best note takers, but they can, or you can, record the consultation, and that recording allows you to time shift and place shift how people can review the information, and that's huge. Even for somebody who has cognitive deficits or language barriers, they may, through a recording, be able to listen in the future with a navigator or an assistant or somebody who can help them process and understand. So that's a really big intervention. The recording is really important. You know, family members, I often suggest to people that if you're going to bring a note taker, bring someone who's not emotionally hooked. Like check your network, your social network, for somebody who's a good note taker. You know, somebody who works as a legal secretary or you know, some ability to take notes. And it's even better if they're a friend of a friend, where they're not like emotionally too hooked. So those are some of the suggestions I make about not really having family members worry too much about the note-taking if possible, but a friend of a friend and a recording and some of this ancillary kind of support. Yeah?
So these examples were people who are post-surgery, they had their diagnosis and pre-kind of future treatment planning. I'm just trying to figure out what this looks like in cases where non-surgical cancers, where diagnosis and treatment planning is given and happens in the same visit, so there's no chance.
Well, yeah, so that might be a need. The question is, well, what about when the timeline is more compressed and everything happens in one visit? Actually, that might be an opportunity to re-engineer the visit flow a little bit. I think there are very few cancers or any other conditions that are such emergencies that you can't create a little space for more deliberation, more reflection, more absorption of information, et cetera. So we actually do intervene with patients who are pre-surgical. It's a question, and from our point of view, the workflow is, how do we pick people up as soon as they have an appointment off of the schedule, and then how do we intervene with them? And I'll tell you, it's challenging. Patients are not used to being, and you know, there are ethical concerns about sort of cold calling patients with materials and services before they've been seen by an attending physician. But that's, again, something that medicine is going to have to get over. It's not all about just the physician's turf, and it's not the physician's patient. So, you know, we're working on sort of improving that kind of process. Yeah, in the back here, and then I'll come back around.
Records that you're creating that are, I guess, new to medicine, like
Yeah.
recordings, do you foresee an increase in litigation or a decrease in litigation?
Yeah, I mean, I think our risk managers are pretty confident that we'll see a decrease. You know, it is an open question. The evidence to date suggests that anything you're doing to enhance communication, and this is definitely considered in that category, is protective. There's another question you're raising, which is a topic of my research. What happens to these documents, especially when they're created? I work in community settings where it's a non-HIPAA covered entity that's providing the coaches, the advocates, the navigators, the accompaniers. What happens when a non-HIPAA covered entity creates these quasi-medical documents? You know, that's kind of a new area of really law. So I'm working with a lawyer at Hastings on treating these documents as copyright, as joint copyright ownership of the patient and the doctor. Anyway, I can get into this technical detail, but it's kind of interesting. I can get into that later. Well, you've already asked one, so let me ask. Go ahead.
It's sort of along those lines.
Yeah.
Since these health coaches are aligned more with the healthcare team, could they, in theory, be named in a malpractice lawsuit?
Right. So could they be named in the health coaches in a malpractice suit? Yeah, I'm just exploring that issue right now because we're trying to bring UC Berkeley students over to expand this coaching program. And in general, with the Patient Support Corps, that's the direction we want to be moving in. And they could be named. What we're working out is that they would be covered by the institution's liability insurance. So they might be named, but the attending physician ultimately and their umbrella sort of policy would be the one covering all that. So really it comes down to actually, it's why I need the cooperation of attendings, is because they need to be able to take on the possible increased hassle or something of being caught up in something with a trainee who's been acting as a coach. And you just have to have, I think, the courage of your convictions to go in that direction. And I don't expect that to be a big problem. So yeah, let me get you, and then back to you.
What can we direct undergrads? Some of us do mentoring to undergrads. What can we direct them to sign up or try to get more involved?
Yeah, so I think in the early days of this patient support corps, the demand is going to be bigger than the opportunity, because I got to get sites up and running. You can refer them to me in the short term, and then I'm not quite sure. We're going to have obviously application and screening mechanisms in the future for other opportunities. But now there is an opportunity at UCSF. We get hundreds of applicants every year for about 10 positions, so it is pretty competitive at this point. Okay, back to you, sir. I think you, or if there's no one, you had another question. Someone else have one? So the question is, has there been any resistance? Yeah, absolutely.